deixei para o fim a nossa convidada especial, doutora Moeti. A doutora Moeti, como já disse, é diretora regional da Organização Mundial de Saúde para a África e é a primeira mulher a ocupar esta posição. É médica, é especialista em saúde pública, tem vários prémios, tem um doutoramento honoris causa e lidera a Transformation Agenda, que é basicamente uma resposta à emergência de saúde, ou às emergências de saúde e à preparação para surtos epidémicos. And now I will address directly to Dr. Moeti. Dr. Moeti, first of all, I want to thank you very much for being with us today. We are all very honored for your participation in this meeting, and please feel warmly welcome to our initiative. I've already introduced you to our audience and also your agenda and your commitment to it. And we are all looking forward to hearing from you, your ideas, your thoughts, and your sharing of your experience. And I'm sure your conference will be very inspirative, very inspiring for all of us. Thus, at this moment, I kindly ask you to do your talk on the topic universal access to health. So, if you please, it's up to you. Thank you very much.
Thank you. Well, muito obrigada. And good evening, boa tarde to everyone. Boa noite, bom dia, depending on where you are. First, to the kind organizers, distinguished guests, participants, my warm greetings to you. It's a great pleasure for me to have been invited to join you in this important event, the Portuguese National Congress of Pharmacists and the 14th Congress of the Association of Portuguese-Speaking Pharmacists. You know, we say that the COVID-19 has changed many things. I've understood that this session is being coordinated by the Fiocruz. I was supposed to visit Brazil and deepen our partnership with Fiocruz when the virus decided to spread, and I could not come there. So I'm very happy to join, even if it's virtually like this conference. Indeed, pharmacists play an indispensable role in healthcare delivery systems all over the world, particularly ensuring universal access to essential medicines and other health products. So I'm very pleased to talk to you today on universal health coverage and sustainability and ethics in access in the WHO African region. Thank you again for having invited me, the Portuguese Pharmaceutical Society, especially the President, Professor Ana Paula Martins, and the Congress President, President Helder Mota Felipe. Thank you for having me here. So if we can go to the next slide, please. In this presentation, I'll briefly describe the progress made globally and particularly in Africa in working towards universal health coverage. And we'll then show the links between action to achieve health for all and safeguarding health security, because we just happen to be in the particular context where health security is at the top of the agenda all over the world. The COVID-19 pandemic has exacerbated equities and challenges in healthcare delivery. And I'll provide some examples of these, particularly around disruptions in access to medicines and medical products, which have been, in some cases, really severe, at least as far as the African region is concerned. I'll then look at the issue of health systems efficiencies, which ties in both sustainability and ethics, and provide some perspectives on the key role of pharmacists in making health systems more efficient. And then finally, I'd like to just touch on some opportunities in the recovery from COVID-19 for how we can improve access to healthcare. Next slide, please. Our priority to WHO is very much supporting countries to attain universal health coverage, or UHC. And the African region is making progress towards this goal with an increase in the UHC index. So we have put together some key indicators around the functioning of health systems and progress towards universal health coverage, and created an index where we see that there has been some progress out of a score of 100 in African countries, progressing from 46 to 48 between 2017 and 2019. At the global level, there has been, when we aggregate the situation across the 6 regions of the world as we define them in WHO, the situation has stayed the same during these 2 years. There has been some political commitment to this, particularly at the level of heads of state in the African Union in February last year. The heads of state committed at the continental level, facilitated by the AU. And this was followed by the very active participation at the UN General Assembly meeting in September last year, which resulted in the political declaration on UHC. So they committed to assure financial risk protection and eliminate impoverishment due to health-related expenses by 2013. We know that in the African region, we have the highest proportion of health spending coming directly out of pocket when people are actually going to seek healthcare, and there is very little in the way of prepayment and insurance schemes so that people can predict a little bit what happens when they fall ill in terms of the expenses that they are imposed to them. The heads of state also recognize that primary healthcare is a cornerstone in making this happen, because it leads to better health outcomes, meaning increases in life expectancy, reductions in preventable causes of diseases and deaths, particularly and including during outbreaks like the situation we're experiencing now. And I've just mentioned there better mental health outcomes, because that's one of the most neglected health problems. And again, the situation of this COVID-19 has really brought it to light because of some of the lockdowns and restrictions of movement, isolation that has been imposed. Also, it can support health systems efficiency with reductions in total hospitalization. So that part of primary healthcare is ensuring that close to where people live, they have a health facility, even if it's a health post, where an essential basic package of services, both for preventing illness, like immunizing children, providing anti-malarial treatments or malaria prophylaxis for pregnant women takes place, as well as then acquiring care and being entering into the system where if they need a higher level of care, they can then be referred. Because we've seen in recent years an outflowing of the construction of hospitals in some of our countries. And we are recommending to governments that if they are going to get value for money out of building these latest big hospitals with the latest equipment, they need also to have primary care clinics where people can start the journey to go into a hospital. Otherwise, then it just increases the inequity, because bigger hospitals tend to be in cities, in towns, and if you're in a village, sometimes it's very difficult for you to reach that hospital in which your government has invested a significant amount of money. We also then think so this is the point around equity, making sure that wherever people are, whatever their socioeconomic status, they are able to receive the key interventions they need, both to prevent illness and to early provide treatment so that they get good outcomes. The next slide, please. What I did not mention is that we are also working very hard with the governments for them to revise their financing strategies. So to shift from this pattern of people having to pay directly for healthcare, admittedly a challenge when quite a high proportion of the population struggle to make their own contributions to their health insurance schemes. But we've seen some very innovative schemes whereby at the community level, with some subsidy from governments, with investment from the private sector in these schemes, in some cases where the populations are big enough and the volume of participants can be big enough to make it even profitable. We're seeing some of these financing shifts starting to happen in countries. then we don't have time to talk about the rest of what happens also around in a well-functioning health system, having a good data system that enables you to know what is going on, that enables you to track what is being achieved in terms of outcomes, that enables you to do surveillance, to detect outbreaks of diseases early, and most importantly, to really monitor impact and to target where the achievements are not as good as you would like. And then, of course, you need human resources for health that are trained, nurses, doctors, pharmacists, other types of technicians to be available, at least at a minimal level, at the most peripheral level in countries to support equity and good outcomes. We have looked at WHO because we recognize very much and have advocated for the fact that universal health coverage and health security, meaning countries being resilient to the shocks of outbreaks, epidemics, humanitarian crises that affect the health sector, are in a sense two sides of the same coin. And then if you invest in strengthening your health systems, it also pays dividends in improving your health security and the resilience of your system to external shocks. This has really, we've seen, been reaffirmed this year with the COVID-19 pandemic, although we need to ask ourselves questions, why have we seen the vulnerability in countries, in the wealthier countries, where according to our indices, their capacity, their preparedness, their resilience should be relatively high. So we need to understand better what else needs to be in place for a system to be truly resilient in the way that we have seen some of the upper income countries not being adequately resilient and experience the severity of the COVID-19 pandemic that they have experienced. So we have here two maps. The one on the left, the UHC service index, is a way, it's a measure of how well the health systems are functioning to deliver healthcare based on some criteria and indicators. And on the right, we carried out some external evaluations of resilience. So how ready and prepared is a country's health system to be able to detect early an outbreak, to be able to respond to this outbreak and close it down early in the way that the COVID-19 has very much tested countries. And although the colors, so the color coding is green is good and red is poor, and you see some correlation among countries that are not doing great. So in West Africa, we have some challenges around the UHC index, in Central Africa as well. And we see that East and Southern African countries are tending to the green, with Algeria. Algeria is our only North African country showing up very well as far as UHC is concerned. We have not yet carried out the evaluation on resilience to outbreaks, but they experienced a quite severe situation with the COVID-19 as well. So what we are recommending is making the link between investing in these two areas or two concerns, so that you get synergy between making sure that people have basic healthcare of good quality, which has good outcomes, and also that you are ready for outbreaks and emergencies. And we see there the situation at the bottom of the slides. We have a couple of Portuguese-speaking small island states, Cabo Verde and Sao Tome and Principe, which are doing relatively well as far as universal health coverage is concerned. And clearly we have to do more as far as outbreak readiness in Sao Tome and Principe. Next slide, please. As I said before, with the COVID-19 pandemic, disparities, inequities, and gaps between and within countries have been exposed and really exacerbated in many ways. You know, if we start again with some upper income countries, we have seen sections of society that are vulnerable in terms of their socioeconomic status be the worst affected. So in the US, it's very much the Black communities, the ethnic minorities, and it's the same in some of the European countries. It was very similar in our worst affected country, South Africa, as well. And we need to look for other aspects of inequity, so poverty, geography as well, has made a difference in terms of the pandemic and in terms of equities in general. So I'm just showing there that even before the pandemic, equitable access to medicines has been very challenging all over the world, and particularly in the African countries. For example, in our region, 23% of children under 5 estimated to be eligible for TB preventive treatment are getting it. The rest, 77% are not. So that's really a matter of equity. We also saw a huge inequity in access to some key items around the response to the pandemic, starting from some essential medical products that were necessary to try out the treatments. And in fact, we have seen, and I have received many distress calls from countries for the fact that the disruption in travel, in transportation, has made them run out of essential medicines. So clearly, the procurement systems, the distribution systems of essential medicines are definitely not resilient to the shock of something like an outbreak, a pandemic that then makes isolation the one way of preventing the transmission of the organism that's causing the problem. And we believe that this calls for such mechanisms to be thought about in advance. We shouldn't wait until we are reeling under the shock of the kind of distortions of the global markets before we start to think about how to solve this problem. One of the exacerbating factors just shown on the right side of the slide was the fact that countries that produce certain items that were essential in the response simply prohibited their exportation. And you can see that dramatically that the African continent is not at all colored among those that did this prohibition, because very little in terms of pharmaceutical items and the kind of items that were needed is actually manufactured and produced in Africa. This was a reminder, it's not a wake-up call. I think the African leadership, political, those in the pharmaceutical sector, those in health are very well aware of this. And there's a certain dynamic now around trying to work within the framework of the African Union to try to solve this issue. And we think that with some of the innovations that are arising out of the response to the pandemic, the partnerships that are being strengthened in a crisis mode between the private sector and the governments, there is really chances for this to shift, to change. Next slide, please. Here, again, just showing that there are already huge disparities in access to medicines across countries. I hope that you can see this slide clearly. I'm struggling to read it myself on my screen. But we've shown certain classes of medicines color-coded, as you can see on the slide, and the difference in access between countries in the African region, because there are differences between countries, and also on average, between countries in the African region and in the Americas, PAHO, which is the region where Brazil is, the US, and Latin American countries. And one of the examples is that the availability of cardiovascular medicines in the capital cities, where you would expect that it is best for that country, is up to 42% lower in the African settings than it is in the American settings. Also, a rapid assessment that has been carried out in 5 African countries found that the direct acting antiviral drugs that are so important for hepatitis C, for example, the availability is less than 30% in some countries like Madagascar. And very concerning, which I guess would be of interest for this audience, is that there is a huge range in the pricing of this, just an example of this medicine, going from about $459 to over $2,000. And I guess it, depending on where you are, this would be a driver of inequity. One of the big challenges in terms of equity to healthcare of good quality that particularly affects African countries is a challenge of substandard and falsified medicines and products, where we get in many of our countries an almost segmented market. So if for the lowest income people who rely on going to a tiny little pharmacy or a market stall or a street corner for their medicines, we understand that is where these medicines of poor quality are circulating. They are the most affordable. And this sometimes acts as a disadvantage. I remember in one country speaking to the president who shut down the market where falsified drugs were being sold, and had a demonstration by low-income people because those medicines that are available in the more formal pharmacies that are likely to be of better quality, according to them, were not affordable. So this is another issue that requires a lot of attention, and in a partnership really between pharmacists, health policy makers, those who carry out procurement in countries, and other sectors that are involved, of course, including those who do customs and are inspecting the quality of goods that are imported into countries. And just a few examples of some alerts of falsified products just in the past year, some medicines, and also some diagnostics, including chloroquine products to deal with one of the biggest health problems that African people have to contend with. Next, please. So in the attempts of African countries to improve the efficiencies of their systems, we know that the medicines bill, the procurement of medicines, is among the biggest proportion of expenditure in the public sector of the government health budget. And here again, and there are many areas of inefficiency in health systems. I think it's not only in the procurement of medicines, in the use of medicines, in the management of the stocks of medicines in the private sector, and how that works perhaps in the public sector, sorry, and how that works perhaps with the private sector. There are other areas, but here is one area where there is huge scope for efficiencies. So starting in the procurement processes, if you like, the pooling of the procurement systems, the working with or without middlemen. And we were very excited to understand, it's about a year ago, that in Angola, the Minister of Health has done a lot of work to improve the efficiency of the procurement system, and in working in certain ways, including cutting out the middlemen, I was told, and working directly with some of the suppliers and pooling the procurement process. They were able to bring down the cost of their medicines quite significantly. And we just think that pharmacists could play a key role in contributing to and supporting this effort to make the systems efficient. Of course, this needs good governance in a partnership among all those who are involved in the pharmaceutical sector, the appropriate legislation, that the regulatory frameworks should be in place, that the kind of common culture of ethics in the sector, in the exchanges, in the procurements, in the sales, in the pricing, in the advertisements be quite central, and of course in the accountability, particularly those who are going to be procuring on behalf of the public sector. We do believe that medicine spending in countries can be made more efficient. And as a profession, pharmacists can contribute also to reducing efficiencies, first in your interactions with those who are prescribing, mitigating against errors. You sometimes are the people that people can speak to when there's adverse events due to several interventions, immunizations, and even to medicines. In regulating promotional activities of medicines, I think you are very aware of how that is done in ways sometimes that are not very ethical. In your interactions with those who are prescribing, in taking part in the training of doctors, we're just giving the example of antimicrobial resistance, where the overuse of antibiotics is one of the drivers of the emerging resistance to the most commonly used and affordable antibiotics, and you think that in the pharmaceutical sector, and particularly pharmacists who see what the doctors are prescribing and are the ones who are supposed to dispense it can support all of this. As I've said, enhancing procurement systems with pre-qualification of suppliers is something that you can participate in. And also some of the innovations, the research that can be done to improve access to the most effective medicines and help to roll them out in the health systems of countries. We've become aware in Africa, for example, that when there are new technologies, interventions, including medicines, sometimes it takes years for them to actually be available in our national health systems for various reasons. And we think the pharmaceutical sector and pharmacists can play a key role in supporting this, working in this multidisciplinary way with doctors, policymakers, and regulators. Next. So what are some opportunities looking forward now to improve access to care, going more broadly after the lessons that we've learned from the COVID-19 experience? As I said, the pandemic has really highlighted that we need to build more resilient health systems, economies, and societies. I won't talk at all about the really devastating economic impact of the pandemic all over the world, especially in African countries. So doing this will require investment, so more financing is needed, both domestic funding, and for African countries, this is going to be a challenge because of the impact on their economies, and also international funding. For low and middle income countries need to pay greater attention to how their domestic funding is used. So how to invest not only more, but invest it smartly, because it's going to be the bedrock of sustainable funding for health, complemented, of course, by international solidarity and international funding. And there's need to use own understandings of how your systems are working to improve these systems. We also think going into the future that preventive measures play an incredibly important role in slowing and stopping transmission of the kind of organisms that can give the shock like the COVID-19 has given. This is a really big lesson, and it's a pointer to the need to invest in a balanced way between primary care, where you are quick to catch whatever is spreading in your country, and where you are able to provide services to the widest number of people, especially the most vulnerable people, which is a cornerstone for UHC, with investment, of course, in secondary care and tertiary care, and with investment in those parts of the system that are most able to detect outbreaks when they happen. It's very important to engage communities, even around the issue of access to care, access to good quality medicines, because people very often have experiences and perspectives and opinions that they can provide, which can inform what policymakers decide to do with their resources. It's also very important for people to be involved in general in the management of healthcare systems, because one of the big challenges we're facing now all over the world, I would say, around the COVID-19 is the fact that it's time to open up the economies. One, and people are tired of wearing masks and staying away from their families and being isolated too. So we need to find ways to re-engage people, to let them feel empowered, enabled, and this should become an ongoing part of the healthcare process and the healthcare system, not something we try and switch on because there's a pandemic and we need people's cooperation, particularly importantly. The partnership between the governments and the private sector has really emerged very importantly during the response to the pandemic, not only in the response, in the work that's going on now in developing vaccines, developing pharmaceuticals, and repurposing production capacity to produce the required volumes of personal protective equipment. That's happened even in African countries. And there is a need to really see how to take that forward into the future more strongly, both at the local level, at the regional level, and also at the global level. So some of the platforms that will be needed next time there's a threat of the pandemic, how to do research together, how to co-invest in order to quickly develop some of the products that are needed to get over these such situations. And then in peacetime, so to speak, how to continue this work to find better treatments for some of the, for example, neglected tropical diseases where the market is no longer great, but which are very important still in African countries, and how to leverage some of the capacities of the private sector, the way they work, their use of data to inform better performance in the public sector. We think these are some of the learnings that we can take up for into the future. There's been a lot of innovation, as I said, that has had to spring out of the response to the pandemic, how to drive innovation and use it as a key component of health sector development and delivering healthcare, finding better ways of doing things that we are trying in WHO to promote very much, that governments should partner with the private sector, because very often that's where you find the innovation in taking forward new ways of doing business. And then finally, that we use technology much more to generate the kind of data that we need for everything that we are doing, starting with dealing with pandemics, but as I said, knowing what's coming in the future, doing some projections, some predictions, both of patterns of disease that might then lead to innovations in developing some of the products, including medicines that are needed, and in monitoring and being able to see where we are making progress and where we are not making progress, targeting our interventions so that we move towards universal health coverage in a resilient way, and the next pandemic finds the whole world better prepared. Next slide, I think, is just to say thank you and goodbye, and thank you very much for having invited me and enabling me to share these experiences and ideas. Thank you.
Thank you very much, Dr. Moeti, for your excellent talk, very informative and also, in some sense, very incisive. Thank you very much.